Roberta, and it's great to be able to talk today. We've just come from the ACTA conference where we've heard all about platform trials all week. We're designing and running one ourselves, and so that's one of the reasons I want to talk to you about it. But it's great to follow on from talking about RCTs to talking about now novel RCTs and how they might be run. So I'm just going to give you a bit of an overview about them in general and what the impacts might be from an ethics committee kind of point of view. So we've heard beautifully about how important randomized controlled trials are and how the design of them is key to making sure that you get a meaningful result from them. And they absolutely are the gold standard for determining causation and evaluating treatment effects. And I don't want anyone to come away from this thinking they're not. But I'm just suggesting that there are some problems with them and there are ways that we can more efficiently run clinical trial research. So this is kind of, as Kelvin said, what a RCT typically looks like. You've got a population of people with a disease. You randomize them normally on a 50-50 basis to either a treatment or another type of intervention. It might be a bundle of care or something else that you do within the clinical space. Or there's a control group, which may be a placebo or receiving standard of care. And then at the end of the trial, you open the envelope and look at and see whether your intervention was effective and improved outcomes for that particular group. And this is absolutely the right way to do things, but there are some challenges in this. A large part of the challenge is you design your study based on a sample size, and your sample size doesn't generally deviate. So you keep going until you've reached sample size, and only then do you look at your data and find out whether it actually was truly powered to find a result. So there are lots of limitations with traditional RCT design, and it often is quite slow to get them up and running. You've got to get funded, you've got to build infrastructure, you've got to build a workforce, and you've got to get the start in all the different sites if you're doing a multi-site trial. They're very expensive to run, expensive to get started, expensive to keep going, and especially if you don't get a result at the end, there's a lot of resource wastage. Generally, you randomize people on a 50-50 basis, and Calvin's told us the different ways that we can do this. But it does mean that 50% of those enrolled in the trial may just get the standard of care or placebo, which may mean that if you keep going with the trial until the very end, a lot of patients aren't getting an effective treatment, and it takes longer, obviously, to get that out into the community if it is effective. We know that trial populations and the sample of patients that we use in trials often don't represent the general population, and that can be a problem in terms of generalizability. That can take a long time to run, so 5 to 10 years is not unusual for a clinical trial, especially in my field, to run before you get an answer, which really isn't acceptable for many disease states nowadays. And medicine is complex. Patients are complex. The environment that we work in is complex. And often just looking at it from a single intervention and versus control doesn't really reflect what's happening in real world medicine. And often what happens in Australia may not be what happens around the world. So being able to look at these kind of trials within global networks is also very important. So there's been a lot of talk about what alternative trial designs might be better, and certainly an adaptive platform trial is one such method that's gained a lot of interest in recent years. So an adaptive design is defined as a clinical trial design that allows for prospectively planned modifications. So we're not just making it up as we go. We say before we start what we're going to do, but modifications to one or more aspects of the design, and that's based on the data that's accumulating within the trial. And that's the FDA's description of it. But essentially, it's a more efficient and pragmatic trial design that allows us to answer more complex research questions more efficiently. So what is an adaptive platform trial? Well, there's sort of two parts to it, and I'll flip them to being a platform adaptive trial rather than the other way around, because I think that just makes a little bit more sense to start with. But the platform as the trial is what you put in place to allow you to run the multiple adaptations. So you have to have one disease that you're interested in, and you want to ask what are the best treatments or what are the best interventions or things that we can do for that one disease. You can't have multiple diseases. We're just focusing on one disease. And to do that, you have one master protocol that outlines what's going to happen for the conduct of the trial. You need to have a common primary outcome so that all the treatments and all the other research questions are all working towards the same goal. And you need to build a coordinated network and trial workforce to allow you to do this. So I kind of think a bit like building a platform is a bit like building a football stadium. This is the MCG because I'm based in Melbourne. And so once you build that stadium, you put your workforce in, they run the bars, they run the ticket turnstiles, they do all the groundworks, etc., etc. They're all there regardless of what you want to ask about. So you can run your AFL grand final, you can have a Taylor Swift conference, you can even have a monster truck tournament, whatever you call a monster truck activity. They can all be there if you've got the platform in place. You don't need to keep building a new stadium each time you want to do something. So that's the same with a platform trial. It allows that perpetual ability to analyze research questions over time. But that ability to adapt is also very important. So you can look at multiple interventions. You can look at multiple arms within those multiple interventions. You can look at different populations over time, depending on what your question is. And so that can be different subgroups, and it can be different standard of care or control groups. You re-estimate your sample size as you go on, because that gives you information about what you're actually learning during the trial, rather than using a sample size that you came up with 5 years ago and hope still stands true. And you do this by looking at multiple different time points and analysing as you go, as well as with your final analysis. As I say, everything's all defined before you start. Your stopping and starting rules, your rules for when you're going to adapt and what types of adaptation you might do, you set out in your core protocol. So it's very clear before you start your trial. And you can assign treatments over time as you accrue data. So you can change the way you randomize patients. So when you find that a treatment is better, but you still haven't quite got there in terms of proving that it's the best, you can actually put more patients into that treatment group to try and get that answer quicker, so that more patients that are enrolled in the trial are getting a better treatment, but also that result comes out quicker and is translated into the clinic. And this can go on and on as long as your trial is running. What does it look like in practice? So you design your trial, you plan your adaptations, you start recruitment, and then, as I say, you do these regular interim analyses to look at the data that's being accrued. You see whether you've met any of the stopping rules. So some of those stopping rules might be because you found that the treatment is the best treatment, it's superior, you want to stop and use that in the clinic, or because it's futile, it's never going to work. Or you keep going because you actually haven't met any of those stopping criteria, and you keep going and you go round and round in that kind of circle until you've got the answers. What does this look like in terms of kind of a practical example of, then this is just a schema. So this is taken from a psychiatric set of trials that you could potentially run. And so this is using a typical RCT design. So you have 5 research questions that you want to ask. So you're going to run 5 research trials. Each of them have their own control group. Each of them have their own intervention. And for argument's sake, they will have a sample size that needs 100 in each group. So you need 1,000 people overall to give you your answers, so a big sample size. You don't know about any of the interactions between drug or intervention A, B, C, D, and E in this, because they're all running separately, and you have separate control groups. And you find after you run your 5 trials that trial 1, 3, and 4 were successful. You get your answer, yes or no, that work well. But you didn't get an answer for trial 2 and 3, and so you've included 400 people without any result at the end that's meaningful. You could do this instead in a platform trial design. So the platform trial has one standardized control group that everyone compares against, rather than having individual control groups for each intervention. And that allows you to have a bigger control group, but also allows you to change over time what goes in and out of that control group. But because you're looking at the data as you go along, and say, for example, you look after 50 patients here, you could see after 50 patients with intervention A, you didn't have an answer, so you kept going to 100, and then you proved that your intervention was successful. After intervention B, after 50 patients, you already know the answer, that it doesn't work, so you don't need to keep going, you just stop there. And you don't need to recruit another 50 patients to a treatment that's ineffective. Treatment C, in contrast, you find after 50 patients that actually it's successful, you've reached your the amount of power that you need and the statistical significance that's relevant. You don't need to recruit patients to that treatment anymore, and you can translate it into the clinic, and so on and so on. So you end up with a much smaller sample size, potentially overall a much more efficient trial, and you get those answers quicker. So the pros and cons of platform trials. So they can answer multiple questions simultaneously. You can ask lots of different things at the same time. There's better statistical efficiency with this type of trial design than conventional designs. There's an ethical advantage. Fewer patients are exposed to potentially inferior treatments. You can understand the different effects in different subgroups, and you can design that up front, and that sort of gives you more of that precision medicine idea. And when we talk to consumers and clinician researchers, there's greater acceptability of this type of trial design and the flexibility that it allows. But obviously, it's not perfect for everything. It's not going to replace the standard RCT. Writing the documents, doing all the pre-trial simulations, getting all the potential adaptations that you might need designed up front takes a lot longer. It's hard to fund things when you're not actually recruiting patients. The biostatistics is a lot more complicated than traditional trial design, so you need specialist expertise, and there's just not currently that amount of expertise in Australia, but we're building that capacity. Your sample size requires simulation. That's a lot of work before you even start, but it does give you much better information about how big that sample size truly needs to be, so you're not wasting resources by having too many or too few patients in your trials. It only really works if your outcome is short term, so you can't look at things. We want to know what happens in 10 years' time, because you can't adapt on 10 years worth of trials, and it does take a long time to get going. But it does work, and it's been around a long time. It's becoming much more popular, but this is not a new type of trial design. There's been a number of cancer studies that have used this, both for phase 1 studies as well as looking at phase 3 studies, and this is a sort of a big example that was conducted in the UK, started in the early 2000s, the Stampede trial, which was looking at prostate cancer treatments, and it has just recently concluded, 20 years after the initial inception of it. So kind of giving you that idea of that perpetual model that's in place there. So they looked at initially standard of care versus a combination of newer chemotherapeutics for prostate cancer, and compared them all at the start. And then over time, as they were able to drop some of these chemotherapeutics because they've met a conclusion, they found out whether it was effective or not, then it gave them the capacity to introduce other therapeutics here, and that meant that the trial could continue. And this standard of care group changes if you prove that this is effective. You then add in, so you can see here, docetaxel was proven to be effective, so that now became standard of care in the later phase of the trial as well. And so this is just a sort of a schema of what that looks like, and then across on this side there's some information about how many patients did they need to recruit, and what was the kind of overall recruitment. So they ended up with nearly 12,000 patients in the trial, nearly 5,000 in that standard of care arm, and then depending on when they got their answer, they were able to get their answer after only 300 patients for this particular arm of the trial, but other arms, you needed 1,500 to be able to get that information. So just giving you an idea of how it does adapt. But I'm sure at the front of most of our minds is the adaptive platform trials that have been used in COVID. And so sort of two big examples here. One is REMAP-CAP, which was recruiting in Australia and New Zealand. It continues to recruit in Australia and New Zealand, but now shifting sort of away from COVID back towards other causes of community-acquired pneumonia, which it was originally designed for. So this is kind of your schema again for a traditional randomized control trial. You want to know what's the best antibiotic, so you run a trial, and you wonder what the best antiviral is, so you have to run another trial. You wonder if steroids work, you have to run another trial. And so that's what we are keen to avoid. Whereas, you've got the same disease, community-acquired pneumonia, and actually you want to know what type of antibiotics, antivirals and steroids to use. So you can put them all within the same platform and get those answers simultaneously over time, because the outcome is the same. And so this is sort of a picture of where they're up to. So REMAP-CAP has now, I think, got over 17 domains, and a domain is a bit like that individual research question or individual trial that sits within the platform. And so within that, so for example, within the antibiotic domain, you may have multiple different antibiotics that you're looking at, but your question is which antibiotic is best for treating pandemic, COVID, acquired pneumonia, or non-pandemic if it's influenza or another bacterial infection. And so the green is those that are kind of still ongoing. The red are where they've got the answer and don't need to recruit to it anymore. And then obviously not every intervention is appropriate for every patient. And so the blue kind of says which ones are not recruiting because it wasn't an appropriate, COVID-19 therapeutics are not appropriate outside a pandemic. But they're chugging through multiple different treatments and interventions over time. And this is really important because over a very short period of time, we needed to come up with a way to treat patients with COVID-19, and we didn't have it. And so within sort of the space of 2 years, REMAP-CAP were able to get those results published in highly impactful journals, and importantly, those treatments were taken very rapidly into the clinic and given to patients when they were shown to be effective. And the other example of that is the recovery trial, which was in the UK, which is also a platform adaptive trial. This little picture here is just taken from the National COVID-19 Clinical Evidence Task Force, just to show you how much was happening in this space. So this is a year old, 18 months old now. And at that point in time, there'd been 4,000 registered RCTs looking at therapeutics for COVID-19. 600 of them have been published, but very few of them actually went on to have enough information in them to change practice, other than those that were taken from the platform trials such as Recovery and REMAP-CAP. So the UK has the wonderful benefit of the clinical trial research network and the ability to flex and adapt to the pandemic quickly with a workforce already in place. So they didn't need to build the platform, they just needed to design the trial. And they did that on a bus journey across London. And within a week, it had ethical approval and was up and running very rapidly in the UK. And this was the first iteration of it. So really simple, pragmatic trial. You were over the age of 18, you were admitted to hospital with COVID, and your primary outcome was, did you die or not? And their treatments at the start were a selection of antivirals, hydroxychloroquine we all heard about, other treatments, and obviously steroids there as well. And then that iterated over time as they found the answer. And they've now had 50,000 patients nearly recruited into the recovery trial at 190 sites, most of them in the UK, but some overseas. And again, within that trial design, they were able to very rapidly show that steroids, dexamethasone specifically, saves lives and should be used for ICU patients, and also other drugs that were already in practice but not for COVID-19. Improves outcomes, but more importantly also showed what doesn't improve outcomes. So we weren't wasting our time, money, and potential side effects giving patients drugs such as hydroxychloroquine and many others. So a highly effective way of getting research answers very quickly if you design it well and you have that platform there to do it. From an ethics point of view, though, it is not without challenges. So I said it takes a long time to write all those protocols, and this is just kind of a schema. The one on the left is the REMAP-CAP schema for their protocols, and the one on the right is SNAP, which is another Australian adaptive platform trial that's running. So as I say, you write your core protocol, and your core protocol really should stay the same and not need to be amended. And that's the first thing that you would submit to your HREC, and that really sets out the structure of the platform, what your adaptations will be for and when, and how you're going to run your trial, the operational processes about it. Doesn't really address any particular research questions other than what the disease process is and why it's important to look at it. And then you have multiple appendixes, and the appendixes are what changes over time and what gets amended and what gets added to. So there are statistical appendices for the entire trial protocol, and then there are ones for the specific domains or research questions. There are domain-specific appendixes, which are almost like a trial protocol in their own right. They don't replicate what's in the core protocol, but they tell you about what's specific to the research questions, such as antibiotics that they're looking at. If it goes international, you also have regional specific appendices, and then there might be other appendices for particular populations that you're worried about, sub-studies you might be interested in, your statistical plans, your health economic plans, and so on and so forth. So multiple different things that will be going backwards and forwards to ethics committees, and certainly during COVID, this was often on a weekly basis, asking for approvals. Obviously, outside COVID, we've got a bit more time to catch our breath and look at these in a little bit more depth. But it certainly is a different impact in terms of what regulatory documents need to be supplied to ethics committees, and also what insurance and what sponsorship and all these other things look like. But they're sort of just important to be aware of. The alternative to that is to do what Recovery did and just amend the core protocol every time they wanted to make a change. So the first start here was, their first set of things that they submitted to the REC in the UK on day dot, and so that was approved within a week. And then they've gone on to amend that multiple times as they've iterated the trial, and they're now up to amendment number 31. So that is an alternative approach, but not one that's been taken largely by adaptive platform trials within Australia. Just wanted to highlight the adaptation platform trial that we're running, because hopefully it will be coming to some of the research offices around the country before too long. And we're looking at trying to improve outcomes for babies that are born preterm. So looking at what we do to mothers during pregnancy and what we do at birth and what we do to those infants. And this I could do a whole other talk on and have often done many talks on, but I think we've just got to be really cautious we don't try to overprotect pregnant women. This has caused harm by the inequity in access to clinical trials for pregnant women in the past. And the COVID pandemic really highlighted this. We didn't include pregnant women in the vaccine trials. We didn't include them in many of the therapeutic trials. And so sitting in the clinic with women sitting in front of you on their way to ICU saying, what treatment can you give me? We couldn't provide them with any evidence based on clinical trial data about what we could do. And this has gone on for many years. This wasn't new to COVID. We've done it with Ebola. We've done it with Zika. We've done it with many, many other diseases that we look after patients in the clinic. So we do just have to be careful about how we judge risk in pregnancy. And I think it's really pleasing to see that the wording in the new national statement will be adjusted to reflect this. So although pregnancy does not necessarily increase vulnerability, recognizing that research can pose serious risk to a pregnant woman with fetus, attempts to avoid this risk has traditionally led to the exclusion of women, and specifically pregnant women, from much clinical research, which leads to a lack of evidence for therapies used in pregnancy. And so despite these potential risks, the participation of pregnant women in research can be of value both to the individual woman, to society more generally. And this is certainly very important where the research specifically addresses matters that are directly related to reproductive health, pregnancy and childbirth. And this includes clinical treatments. I don't think we can carry on saying we don't have any evidence to support the clinical treatments that we're using, because it just means you're experimenting on people in real life rather than doing it within the controlled environment of a controlled trial. And so my piece is that the default must no longer be exclusion of pregnant women from clinical trials, and not really whether they should be included, but how. The trial that we are starting is the PLATIPUS trial. It's a platform for adaptive trials in perinatal units. And these are trials that are really looking to improve outcomes for babies born preterm. Why is this so important? Well, 12% of all births occur preterm. That's 15 million babies worldwide every year. 1 million of those babies die, 1 every 40 seconds. In Australia, there's 25,000 preterm babies born every year. And it's the leading cause of death in children under the age of 5. And survivors of preterm birth have the greatest burden of complications than any other disease, worse than cancer, heart attack, stroke. The burden of disease after being born preterm is really very important, and we need to be doing better. We can't reduce the rates, but can we improve the outcomes? And so these are the sort of things that might happen to a mother and a baby if they're at risk of preterm birth. There's things that we do to mothers during pregnancy to try and improve their outcomes. There's things we do to the baby when it's born, and there's things that we do to the baby in the nursery to try and give it a better chance of a successful life with less complications. But many of these are not based on clinical trial evidence, and now's the time really for us to address that, and a platform trial will allow us to do this. So we have an investigator-initiated adaptive platform trial that's funded by the MRFF to get started. We'll be assessing multiple interventions during pregnancy and in the neonatal space. So recruiting women at risk of preterm birth and their infants after birth across the maternity hospitals in Australia, New Zealand, and then potentially internationally. And our short-term outcome is looking at, primary outcome is looking at short-term neonatal morbidity and mortality, recognizing that many of these things are a surrogate marker for longer-term health and important outcomes to parents and families. And if we do something to the mother during pregnancy, we're obviously also collecting information about the outcome for the mother, but not so much for interventions that just happen with the baby. And this is our team and our networks and our supports. So we are one of many adaptive platform trials coming to Australia to answer important research questions. So hopefully this just gives you a flavour of why we should do them and what they look like. Thank you.